Hello, everyone. I think we are going to start now, and my name is Deepa, and I'm with a feminist human rights public health organization called Sama Resource Group for Women and Health, which is based in Delhi, in India. And I'm delighted to welcome all of you to the webinar on grounding health systems and gender equality to achieve universal health coverage. It is wonderful to have you all join us today, and a very warm welcome especially to our speakers, whom I will have the opportunity to introduce later. Before I move ahead, I would like to share a few important logistical announcements. All participants, please type your questions throughout the webinar in the Q&A function and not in the chat box. I repeat that please type your questions throughout the webinar in the Q&A function, not in the chat box. These questions will be addressed after all the speakers have presented. The webinar will be recorded and shared via email. For those of you engaging on social media, please use hashtag #GenderUHC. I repeat, hashtag #GenderUHC. For all of you engaging on social media, please use that hashtag. We also invite all participants to join the Alliance for Gender Equality and UHC. The link for this will be shared in the chat box and by email after the webinar. So we look forward to having all of you join us in the Alliance. I want to start by introducing the Alliance briefly. This webinar is being organized by the Alliance for Gender Equality and UHC. Briefly, the Alliance is co-convened currently by 5 organizations and comprises over 200 diverse organizations and networks from global regions and countries. The Alliance for Gender Equality and UHC has been a leading voice championing a strong gender focus to UHC. The Alliance was intensely engaged in processes leading to the 2019 political declaration of the high-level meeting on UHC, which many of you would have followed. It continues to mobilize and build momentum for prioritization of gender-responsive UHC, the inclusion of sexual and reproductive health and rights for gender equal, inclusive, sustainable, and resilient health systems. This webinar is one such effort of the Alliance. With regard to the context of the webinar, briefly, the webinar is situated in a context where, as we all know, there are threats to the health and rights, especially of girls and women from marginalized communities. This is the reality in most of our countries and regions. While some progress was reflected by the UHC political declaration last year, there is a long way to go. These threats include barriers to access determinants of health for girls and women, and persisting global and local structural and intersecting inequalities. Health systems continue to grapple with inadequate budgets, infrastructure, skilled and adequately paid healthcare workers, safe working conditions for them. Non-prioritization and opposition to SRHR and necessary information and services, and the overall lack of strong gender responsive health systems have been historical and significant shortfalls. The COVID-19 pandemic, which all of us are in the midst of right now, is exacerbating these intersectional structural inequalities and exposing the fractures in health systems. In India, where I am from, responses to COVID, such as lockdowns, containments, have aggravated social and economic deprivations. Many of you would be familiar with the media reports and images of lakhs of migrant workers, including women and children, walking miles to reach home with serious impact on their health and lives. There is an increased burden of reproductive and care work for girls and women, and violence against girls and women in private and public spaces. Health systems are still mostly restricted to COVID, with non-COVID services largely unavailable. Availability of only skeletal sexual and reproductive health services on the ground has affected access to maternal health care, abortion services for violence survivors, mental distress, etc. these probably resonate with the context in many countries, and we are going to hear in more depth from our speakers. Given this context, the webinar objectives are meant to illustrate that health systems based on UHC and grounded in gender equality, from decent work to financing to SRHR, will improve health outcomes for all and foster strong, resilient health systems able to withstand crisis and deliver for the long term. It will also, we are hoping, underscore the imperative for continued investment, commitment, and momentum for gender equality in UHC, including SRHR, and in the health workforce and leadership. I would like to now call upon and invite our first speaker, Dr. Nono Simelela from South Africa. Dr. Simelela is Special Advisor to the Director General on Strategic Programmatic Priorities at the World Health Organization. Prior to this role, Dr. Simelela was WHO's Assistant Director General for Family, Women, Children, and Adolescents. She has more than 30 years of experience as an obstetrician, academic advocate, and government official, and has previously served as Special Advisor to the Vice President of the Republic of South Africa on social policy, where she supported the multi-sectoral government-wide response for HIV. Dr. Simelela, over to you. We look forward to hearing you, especially your insights on SRHR in the context of UHC. Thank you. Over to you, Dr. Simelela.
Thank you. Thank you very much, Deepa, and a warm welcome to all the speakers who are going to be part of this conversation, and to all the participants. I'd like to thank you all on behalf of WHO, the conveners, as well as all our friends and colleagues across the world. We are indeed living in an unprecedented time. COVID-19 has turned the world on its head and exposed the fault lines of our society. If humanity does not learn from this epidemic, we are bound to be doomed. But knowing that all of you sitting around this table are champions and fighters, we do believe that we will triumph. Thirdly, this epidemic will impact disproportionately on the world's poorest, as outlined by Deepa. All the issues that face young women and girls across the world are going to be really sharpened and much more exacerbated. Second slide, please. This is just some data that comes from a report that has been published demonstrating the work that is being done by WHO with its partners, Women in Global Health, and many others, that just shows the role women play in the global health and social workforce. Whilst we see these inequities, we also recognize that there is some progress being made. This report, titled Delivered by Women and led by Men, does not pull punches in terms of what needs to be done to achieve gender transformative policies and health systems that will really provide dividends to communities, women, families, and society at large. It's a double-edged sword to note that women constitute 70% of the world's health workforce. Although this is good, we know that in the context of COVID-19, this has meant that women are now facing the brunt of this pandemic, being at the front lines of healthcare delivery, and more importantly, facing the brunt at home, as you know that levels of violence have been reported to have increased drastically during this time. We therefore see that although the report I'm referring to projects that there will be a need for up to 40 million more jobs in this sector by 2030, if we do not address the gender inequalities that persist in this sector, women will still be disadvantaged. So we really need to be putting every effort into ensuring that we deal with this. As we speak today, we are sitting at over 5 million people who are confirmed with COVID, with over 328,000 deaths. And these numbers are not really the most important in that we know that we're talking about people who have been tested and that mortality is likely to be higher. Unfortunately, we have yet to see the impact of this pandemic on Africa, which has weak health systems, as well as a triple, in fact, quadruple burden of disease. Next slide, please. What has WHO been doing to champion UHC, gender equality, and the issues that pertain to women and girls? You all know about the landmark declaration that was adopted at the UN high-level meeting in 2019. What was important about that declaration is that heads of state made very, very important commitments to provide better opportunities for women, to mainstream a gender perspective, to include sexual and reproductive health, free of coercion and discrimination and violence. And these are important things because as a community, we can hold governments to account for all of these commitments that they have made. These declarations really show that there is no development without health, and certainly no sustainable development without investing in quality SRHR services for women, young girls. We are not excluding the boy child and men, but we really want to focus on women who have been consistently disadvantaged. WHO also launched the UHC report, which for the first time had a gender chapter. And that is very important. I would urge colleagues to go and look at the specific issues that got highlighted in that report. We also had a launch of the Global Action Plan. Very important because here in this action plan, 12 agencies that together are responsible for a third of development aid going to LMICs have agreed to work together. This is very important in the context of this pandemic because it will lessen pressure on governments to deal with aid and help us streamline all the issues that we need to focus on. In addition, WHO and partners like the World Bank and others continue to provide the relevant information on financing, on best buys, and on how governments can continue to improve access to services for the most marginalized and for women and girls particularly. Next slide, please. Lessons learned from COVID-19. I think Deepa mentioned some of those, but we have seen across the world, developed and developing countries, the weakness of health systems. Therefore, this must be a lesson for all governments and ourselves as stakeholders that we need very, very strong health systems and primary health care as the best defense against outbreaks. WHO is looking to review international health regulations after an assessment of how the world has responded to this pandemic has been conducted. We will strengthen those rules to make sure that we do not ever expose the world to such a pandemic. We have seen that countries have really neglected ensuring the continuation of essential health services, and this is something we must continuously remind governments to do. Several documents, guidance documents, and all the relevant information governments need to sustain these services have been provided by partners, by WHO, and we would like to encourage all participants to visit our website, amplify those messages, demand those services, and help women access care. Next slide, please. How do we intend to take this work forward as WHO? You know that since the pandemic really has visited the world, the WHO, under the leadership of the DG, has launched several very critical initiatives. We've got the Solidarity Response Fund that has got multilaterals, international financial institutions, philanthropies, and private sector, many, many partners working together to ensure that developing countries and those that are under humanitarian conditions everywhere across the world, there is equitable access to the commodities that countries need. The solidarity trials give us comfort because they are spread across the world, testing different therapeutics, vaccines, treatment and diagnostic commodities, and people working not just from WHO, but with other partners who have expertise in supply chain to make sure that countries receive the commodities they need, healthcare providers, women in particular on the front lines, have PPE and all the things they need to ensure that they respond appropriately. We've got the ACT Accelerator, which is already moving forward. All players involved, communities will be part of this as well, to ensure that anything that comes out of these trials is made accessible to everybody. Equity, transparency, accountability, solidarity being the principles that have continued to drive WHO's leadership in this area. So there are many lessons that we are going to be learning, that we are already learning. And we believe as WHO that the world will not be the same. It will not benefit us to go back to business as usual. All these partners that have now corralled to move the world forward must stay committed, because the impact of this pandemic is going to be felt for many more years to come. So we believe that these new relationships set a new standard for how to do business in a global health community across the sectors of society. Most importantly, maintaining women and children and young people across the world in the center of the things that we do. Next slide, please.
Dr.
We will
Nono, I think we're out of time. So I was wondering if you could, we could bring back some of these issues during the Q&A.
Thank you very much. Thank you.
Thank you so much, Dr. Similela, for your presentation and giving us an overview from the perspective of WHO and flagging all those issues on gender equality. Now, I would like to invite our second speaker, Ms. Rosario Valdez Fernandez from Chile. She is a midwife and president of the Syndica Foundation. Ms. Fernandez has practiced midwifery in Chile and Uganda, and she founded the Syndica Foundation with the mission to support midwifery training and services in Iganga, Uganda. Over to you, Rosario.
Hello, well, as I was just introduced, my name is Rosario Valdez. I'm a Chilean professional midwife, and today I'm going to be speaking about how is to be a frontline midwife and how is gender equality in Chilean health system, what had we already achieved, and what are the goals that we are still missing. If we can go to the next slide, please. Well, first of all, and just to get you into the context of Chilean situation with COVID virus, since last week, we got into the peak of the curve. Just yesterday, we had the day with more new cases, reaching over 4,000 of them, which get us over the 53,000 cases in total in a population of 19 million inhabitants. Situation that has already collapsed hospitals. The quarantine has been extended and has been tougher day by day, and now hunger is becoming an active problem. So, in between all this situation, I think we as midwives had realized of three challenges in women health. First of them is the invisibility of women. Today, we have no programs to guarantee our patients family planning or respecting their sexual and reproductive rights during the pandemic. For example, at the beginning, there were no statistics that included pregnant women COVID positive, knowing that the management and treatment of pregnant women are always different from adult patients. Second of all, we do not have an official ministry protocols for the treatment of pregnancy, labor, and newborn to assure them the correct treatment and a positive experience in reproductive context, even during a pandemic. And finally, the third point is how we midwives have not been recognized as frontline health workers. Actually, in the Latin American ICM statement, 58% of the professional midwives do not feel safe enough with the personal protective equipment provided. So we could say that most midwives are professional women taking care of women patients, not enough valued to be assured with correctly personal protective equipment. not just because midwives are important in health system, but because our main patients that are pregnant women and newborn should always be considered critical patients. Now, if we go to my personal and emotional experience, there are two main things that I think that had been like the tougher ones. The first one is that when the COVID started spreading in Chile, visitors at some hospitals, including the one that I work at, had been forbidden, including by visitors, the father or the next of kin from the patient during the whole hospitalization. So attending a delivery with a patient that it's already alone and in a context that the physical contact is not recommended, you leave that woman so alone and you're not able to contain her. That's something that really tears you apart as a midwife. And then in the second situation that has been in my experience like the tougher one is to see all my colleagues being apart from their kids, being afraid of touching or even getting near to them and spread them or their families. So my colleagues that had left their houses and families are really tearing apart. Well, of course, in being frontline, there's hundreds of feelings and frustrations that you have to deal with day a day when you're a frontline. I could be hours speaking about it. I just think that now we should all have to work out our empathy and take care of each other. But as well, we all know in health, show must go on. So if we can go please to the next slide. I would like now to speak to you about our second theme, that would be the gender equality in Chilean health system. I divided this part of the chat in three main parts. That is, how is Chile today? Then what are we missing? And finally, which are our goals in the future? Well, by the definition of the World Health Organization, essential health service in reproductive, maternal, newborn, and child care should be measured in 4 categories, which are family planning, antenatal care and delivery, full-time immunization, and health-seeking behavior of pneumonia. Chile achieved with the 4 of them. And if you can see at the slide, we also count with a woman program that includes health prevention with Papa Nicolau and mammography testing, both of them helping us in prevention of cancer. Then you can see the reflection on point number 2, the reflection of the family planning work with really good rates at adolescent pregnancy with only a 7.8 of adolescent pregnancy rate. Also, you can see, we have been known in Chile as having low maternal and neonatal mortality rate, which could lead us into a really good state in health. But if we can go to the next slide, please. We are still missing a free and safe abortion law in Chile. Women are shouting for it in the streets. I think it's time to hear them and respect their sexual and reproductive health and rights. Today in Chile, we only count with 3 causes for legal interruption of the pregnancy, but this is certainly not enough. Women are not feeling respected in their sexual life. Then the second point is sexual education, where I must say that it really embarrassed me because Chile does not count with sexual education in any time of a student life, not in school, not in university. And this gets us straight into the next point, that is the outbreak that we are living about HIV. In between 2010 and 2018, there were the double of new cases. Number that it's shocking, but it actually responds perfect to a population with not sexual education. So if we can see, it's not just about the essentials that the World Health Organization define, it's so much more. I think that when it comes to maternity and newborn care, the World Health Organization and the universal health coverage, should we always be talking about quality, not only essentials. If we can go to the next one, please. Yeah, now if we try to see which is the future and the hope that we have for gender equality in Chile from my midwifery approach, I hope that we continue growing in health prevention. We are having a huge challenge, especially in HIV, as I just mentioned. We need professional and personalized care of the delivery. Actually, in Chile, we have 97% of the births are attended by professional. The thing is that The personalized attention we have not arranged to, because we are usually overwhelmed in work, so we cannot manage to do a personalized work. We are needing birth houses just close to the hospital, but not in them, so we can try to decrease our instrumentalizations, since Chile has like one of the highest rate in C-sections. Well, if you can see, there are a lot of goals in the slides, and actually, I think that when you talk about maternity care and newborn, there will never be enough goals. If we can go to the last slide, please. Well, now I would like just to make a reflection about what I've been talking about. I think all these programs of prevention in health system, sexual and reproductive rights, and gender equality in Chile are run by midwives. Midwives that most of them are women. Women in Chile represent 70% of the health workers, but only 20% of us are included nowadays in decision making. We as midwives need to be included in preparedness, response, and recovery phases of risk and disaster management programs, and considered as part of the healthcare teams during a health emergency or disaster. We must assure our patients a positive experience in the reproductive context, even during a pandemic. So I think as long as they include us in the Chilean health system, would be stronger and support the achievement of gender responsive linked to the universal health coverage goals. So this is more or less what I wanted.
Rosario.
Sure.
Yeah, will you be able to wrap up now so that we can move to the next speaker? We can take up questions during the Q&A.
Okay.
Thank you so much, Rosario, for that presentation and for sharing your experiences as a midwife and the challenges for frontline healthcare workers in Chile. I mean, the challenge for frontline workers has been huge across the world during this pandemic, and it also reflects the situation otherwise for them. So we hope there'll be more questions for discussion during the Q&A. I'm very pleased to invite Dr. Lia Tadesse, our next speaker. Dr. Tadesse became the Minister of Health of the Federal Democratic Republic of Ethiopia in March 2020. Prior to this appointment, she served as State Minister of Health since November 2018 and led the national health programs under the Health Sector Transformation Strategy. Dr. Tadesse has extensive experience prior to joining the Ministry of Health, and including serving as Program Director at the University of Michigan Center for International Reproductive Health Training, and as CEO and Vice Provost of St. Paul's Hospital Millennium Medical College in Addis Ababa. Thank you, Dr. Tadesse, and we really look forward to your presentation. Over to you.
Thank you very much, Deepa, and greetings, everyone. I would first like to thank the Alliance for Gender Equality and UHC and the co-convening organizations for organizing this important webinar and for inviting me to take part to share a little bit of Ethiopia's experience. And this is really a timely meeting during these unprecedented times when we are facing a global pandemic, which is putting our health systems to test and our collective responsibility. And we all, I think, agree the current realities have exposed social disparities on many levels. And even though women are serving at the forefront, they continue to bear the brunt of the economic and health impact of this crisis, and additionally enduring domestic violence. Next slide, please. Just to say a few words on Ethiopia, it's a country with 110 and above million and above, with 2.6 population growth rate. Total fertility rate is now at the current data shows 4.2, and we're progressively improving in our contraceptive prevalence rate with the current data of 40. Next, please. Next slide, please. In the past 2 decades, Ethiopia has made significant progress in creating access to health through mainly decentralization and to the lowest level and forging partnerships with different stakeholders and focusing on universal health coverage has been the primary grounding, especially through a strong primary healthcare system. And the foundation has been also really making this health system gender responsive. And some of the things we have been doing in the health sector strategies to ensure equity, quality, and compassionate care has been one of the main agendas, and also ensuring that the reproductive, maternal, and newborn and child services are the core of UHC, and really ensuring that this is provided in a life cycle approach for women. And the community health program of through the health extension program, which is up to the household level at the lowest level, has really progressed the access to women's health, and these are all women health extension workers, and making services for reproductive health services free of charge at all level of the health system has been one of the achievements to ensure improvement in the access to services for women. Next slide, please. And there has been an improvement progressively in the political commitment to ensure gender balance especially at the higher leadership level, and this is really, we see that a step in the right direction for Ethiopia, with really increasing the role of women significantly. And today we have our first female president and a gender balanced cabinet in the history of the country. However, as I said, this is a step in the right direction, because as you go down to the tier system, the gender balance still is a big issue that we are working on. And at the ministry level, there's a lot of initiatives, and we have good gender balanced leadership. But when we go down to the regions, up to the district and health facilities level, we see there's still a long way to go in terms of improving a woman's involvement in the healthcare leadership. Next slide, please. And to facilitate this continued growth in leadership of women in different levels, they should also be, the health and well-being must be secured, and interventions outside of healthcare also are crucial in improving gender equity in accessing women's education, access to jobs, and poverty reduction. Among the achievements through the health extension program, also addressing unsafe abortion has also resulted in massive gain in women's health and reducing mortality in Ethiopia. However, we also see that improving access to care is not enough. Services should be also of high quality, respecting women's rights and privacy. So this is also one of the key areas that we're trying to work on, in addition to bringing more women into leadership positions at all tier system. Next slide, please. So we have still a lot of challenges remain. While we are seeing a lot of progresses, still the service utilization by women and girls still low, with need to improve the quality of care. Although Ethiopia has progressed a lot in terms of the reducing maternal mortality and improving access to contraceptives, we still have one of the highest maternal deaths and unmet need, and also issues like child marriage and gender-based violence. Next, please. So when we come to the COVID time, so it is already showing impact on SRH, with shifting of leadership focus, and also facilities and professionals hesitance to also provide those services due to PPE and other issues. So there is a key initiatives we are taking to ensure that facilities are prioritizing key essential services like RMSH and SRH services that should get attention in this outbreak, and also trying to introduce We're planning also to introduce other innovative approaches with other partners, like home-based self-care packages, as well as teleconsultations to ensure women are accessing services in this critical time. So we really hope to learn more from other partners and organizations as well in this regard. Thank you so much.
Thank you, Dr. Tadesi, for your very insightful presentation and walking us through some of the experiences and challenges for Ethiopia, I mean, in general, but also in the context of COVID. To all the participants, unfortunately, Dr. Tadesi will not be able to stay for the Q&A as she has to leave. But we thank you and we hope to hear further from you in other forums and really learn more about the experience of Ethiopia, which has taken quite a while to reach where it is, but it has been an extremely insightful experience and presentation. Thank you once again. I would like to now invite our next speaker, Mr. Arush Lal. Mr. Arush Lal serves on the board of directors for Women in Global Health, where he pushes for gender equity and intersectionality in global health leadership. He is also currently an international consultant at PAHO, PAHO, and the World Health Organization, supporting member states to improve access to essential medicines and public health supplies, including in COVID-19 response. Mr. Lal has previously worked with IntraHealth International, the US HHS Office for Global Affairs, Pandemics and Emerging Threats Division, and Friends of the Global Fund for AIDS, TB, and Malaria. Over to you, Arush. Thank you.
Thanks so much for having me. And it really is great to hear from so many colleagues who are engaged in this work in different ways and from different perspectives. I just want to take a moment first to note just how important these issues are today in the context of COVID-19. Health emergencies and crises really do put an incredible strain on health systems, and they bring into stark relief the major gaps that may have been lying under the surface for decades. Even nations that have been lauded as the gold standard for readiness have been caught flat-footed. And though it's still early, countries that have taken the time to invest in UHC may actually be faring better. And equity is, I think, one of the most important of these issues that we see. How we choose to respond moving forward will determine our ability to ensure high quality care for all while being resilient to future public health threats. Next slide, please. So I want to preface, so the first important section to look at is gender inclusive decision making for UHC. And I want to preface this by first noting the need for sex disaggregated and intersectional data. Simply put, right now we're working blind, and when we don't have necessary data, it seems that fewer than 40 countries are reporting sex disaggregated data on infectious diseases and mortality. And this really inhibits our ability to ensure a more gender inclusive response. Looking at women's leadership, I know many folks have touched on this, so I'm just kind of gonna go over the main areas that might have been missed. So women, as others have said, represent about 70% of the health workforce, and even 90% of frontline health workers who've actually been responding to COVID-19. But they represent less than 30% of leadership roles, even while delivering health services to around 5 billion people. And this is a real shame, especially when you note that women have a triple burden when it comes to epidemics. They face high risk of exposure due to clinical infections in their role as health workers. They have lost opportunities due to school closures and unpaid family care. And they have heightened risk due to ill health from diverted resources and that impact women in particular. And in the context of COVID-19, we've also seen a much higher risk of women with gender-based violence, and they're more likely to have to be responsible for the 1.5 billion children that are out of school today. This drastically impacts their ability to be financially independent. And an interesting study that a few colleagues had done recently with Women in Global Health showed similar sectors that peace processes led by women were 35% more likely to last, and yet only 13% of peace negotiators are women. Similarly, in business, women have been shown to have higher innovative and ethical decision-making yields, and yet they're often excluded from leadership. Similarly, though, men's health is an important issue that's not considered when men aren't included in gender equity conversations. You know, it's time that we take a gendered approach to see where men are overrepresented and where they're underrepresented in the health workforce. The Global Action on Men's Health has done some important work highlighting this, and they see a lack of participation in gender equality, making a minority of nursing and social care positions. Almost around 10% of nursing positions are held by men. And we need to address the gendered norms and stereotypes that deter men from entering female majority professions. And this is a real issue for men in particular with COVID-19, because we're seeing early data showing higher numbers of male deaths from this. This may be due to biological and behavioral factors. We're looking at maybe higher smoking rates and underlying conditions, lower life expectancy for men. Also, men's behavior in terms of increased isolation, depression, anxiety, even high rates of suicide are major issues that men have in health that are often underappreciated due to a lack of focus on gendered impacts. And I want to note that in both these cases, in particular, men also are less willing to seek medical help, and this makes it really difficult for men to get the care they need on time. And I want to note, especially for both of these issues, that minority groups are disproportionately underrepresented in gender decision-making, and maybe more susceptible to these impacts. WHO expert advisory panels show that only 11% of members were from the Africa region, and patterns of inequality in decision-making are reflected in who sets the research priorities that inform policy and who makes these decisions. Racial minorities and lower socioeconomic groups are also similarly seen to have higher rates of underlying conditions, and yet are excluded from decision-making. Next slide, please. So when we look at decent working conditions, the High Commission for Health, Employment, and Economic Growth showed a lot of important information on how UHC has been, some of the gaps in UHC, especially as it relates to the health workforce. We see around 400 million people worldwide lack access to healthcare, and 18 million health workers, the world will face a shortage of 18 million health workers by 2030. And this is critical to UHC because it relies on these health workers. When it comes to, when we look at equipped workforces, we've seen terrible stories in COVID-19 of a lack of personal protective equipment for health workers, and even seeing young health workers having to make difficult decisions about who should live and who should die due to limited PPE. In addition, when you look at gender, personal protective equipment is often made for women, is often made for men and not designed to account for women, which is a huge issue when it comes to protecting our health workers. There's also a major issue of unpaid care. Women make up take the unequal burden of care, which require access to child and elder care, and they make up the majority of this unpaid work, which drastically limits their ability to have economic opportunities. We also see a lack of women, as I mentioned, in diverse leadership roles, and they must be heard. Minority leaders in particular that come from different backgrounds and skill sets have to have their voices heard if we're going to continue relying on them as health workers that are effective in their jobs. And when you look at protected and safe health workers, many frontline nurses and midwives are women that can come from already vulnerable groups. In crisis settings like refugee camps, there have been reports of targeting women health workers, and there's a concerning trend in rising attacks on health workers in the DRC, even in West Africa Ebola crisis, in Syria, and this is a huge issue when it comes to universal health coverage because it deteriorates trust in the health system. And we finally have to manage the health worker migration and ensure that workers are incentivized to remain in country. Next slide, please. So contextualizing UHC in COVID-19, there's 4 kind of main areas that I see as key issues. The first is vulnerable groups are particularly impacted, and they have specific needs that need to be addressed within UHC. LGBTQI groups are routinely left out, and these groups often have mental health issues, which are one of the major unmet needs for these groups in particular, but in UHC, they're often excluded from discussions. Vulnerable populations may require access to SRH, sexual reproductive health services, and emergencies and lockdowns can impact LGBT groups the hardest, where they face a higher rates of gender-based violence and stigmatization. As well as I've mentioned previously, how race and ethnicity plays a role in this. Black adults have at least 50% more likely to die from heart disease and stroke than non-Hispanic white adults. And they're also shown to have lower rates of health insurance, which makes them more susceptible to issues like COVID-19, but even ongoing routine services. We've also seen in COVID-19 a lack of access to healthcare with disrupted routine health services and inequity in resource allocation. And this is concerning because during the West Africa Ebola crisis, more women died from an excess maternal mortality than from Ebola itself. And this is primarily due to disrupted health services. We've also seen a 50% drop in heart attacks reported to the NHS. We've seen a lack of access and disrupted services for HIV medications, cancer screenings, breast cancer for women. And these may be unreported, which may cause huge issues to the health system down the line. One of the most concerning issues we've also seen in terms of access is a lack of equity. We've seen high-income countries racing to stock up and stockpile resources, while low-income countries have to ensure that they can maintain what limited resources they have. And we have to ensure there's a plan to ensure vaccines and other resources are equitably shared and redistributed based on need. Fragile systems, many countries have a lack of public health infrastructure and ongoing crises. And even high-income countries like the US and UK have struggled due to a lack of political leadership and delayed action. And then finally, with misaligned priorities in governance, we see vertically siloed systems that can make a focus on services for women like sexual reproductive health and maternal health an easy target for funding cuts. And we have to ensure that different—
Arush, you'll have to wrap up, please.
Sure.
Sorry to interrupt.
Sure, no problem. Just the last slide, if you could go to that.
Sure, just
so just the four main areas.
Quickly though.
So just the four main areas we want to look at are sex disaggregated data, having more gender responsive health systems, looking at the social determinants of health, and having more global solidarity when it comes to gender equity. It's time that we have a real shift in gender equity for UHC, and this can ensure a more resilient universal health systems and deliver more inclusive care using a health for all mindset. And I can address some questions down the line. Thank you.
Yeah, thanks, Arush. Sorry to kind of push you, but we will have time during Q&A. I'm sure we'll have many questions coming in on that. Thank you so much. I think you drew attention to vulnerable communities, including healthcare workers, fragile systems, and of course the politics of health priorities, very relevant points, and hope to discussing this further. I would like to invite our last speaker for this webinar, Ms. Patricia Nudi. She is the Advocacy and Policy Lead at the Kisumu Medical and Education Trust, KMET in Kenya. She holds a Bachelor of Laws degree, has vast experience in health law. She has managed advocacy-related projects on sexual and reproductive rights, family planning, gender-based violence, and accountability and mobilization. Patricia, the Zoom is all yours.
Thank you, Deepa. Thank you, everyone, for joining. This webinar is coming in at a very timely, because it comes at a time where our health system has been greatly tested, with women bearing the greatest brunt, just like in most pandemic we have witnessed before. So I will begin by really sharing our Kenyan UHC experience and go down to our COVID situation currently. Next. Like most countries, the drivers for inequality in UHC implementation in Kenya lies in gender inequalities and power dynamics. In both cases, we have seen that women are greatly disadvantaged. And so I will kick off with the 5 points that I came up with in regards to what really is our experience as a country. The first one is SRHR, sexual reproductive health financing. We have noticed that women incur more out-of-pocket expenditure than men. This could be in part attributed to women's specific health needs related to pregnancy, childbirth, contraception, among others. But we have also seen that public financing doesn't really factor in this reality. So we witness frequent commodity stockouts, inadequate budgets where it matters. And in our social insurance scheme as a country, we have noticed that postnatal care, for example, doesn't really look at the issue of postnatal contraception because it's a standard reimbursement, although in paper, it is said that they cover postnatal contraception, but in reality, and when money is now involved, there is really no money that is attached to contraception after postnatal. We've also seen cases where permanent methods are only available for civil servants. That is in our social insurance scheme. So it gets you to a point where you realize that financing doesn't really factor in most of the crucial things that women would require. In the essential benefits package, it is key to note that family planning, for example, is not included in the Kenya's UHC package. It is very concerning that we have seen women's reproductive needs are being narrowed down to maternal health. So long as you can go to the facility and deliver for free, the system assumes that you are fine and you should not be complaining about lack of rights. We've also seen that diverse needs of women are not taken into account during policy development and implementation. And this is even when services are available, girls and women may not be able to access them. And we've seen this across board. But there is lack of access to and control of economic resources among the women. There is discrimination. We still have harmful gender and cultural norms and practices that still continue. Lack of information. And we've seen that age, socioeconomic status, decision-making power, education level are all determinants of health. In Kenya, for example, we have met the AFP 2020 contraceptive prevalence rate of 58, while married women in northeastern part of Kenya are still at 2%. So the disparities are huge. Adolescents are still unable to access services easily because there's a number of bottlenecks in the system that still invalidates their capacity to consent to services. And policies and decision-making doesn't really reflect such realities as we see it. The second last issue is on the coverage versus quality. And in addition to ensuring that coverage through financing and demand creation, health system factors such as health workforce, supply, service delivery, governance, and a strong information system with disaggregated data has not been strengthened to a point that we can say that we are giving quality services. And the non-discrimination factor still comes in a lot in our system when women get to access services. And lastly, in Kenya, we have a free maternal health, and I've put that free in quotes, because we still find that it has been marred with a number of inadequacies. On paper, for example, it covers maternal health comprehensively, but in practice, it covers women until they give birth. So any complications thereafter or any newborn needs that arise thereafter are at the cost of the client. At times, clients are forced to buy razor blades and cotton wool when they go to a facility. Women share beds and some still deliver on the floor. It is unacceptable. And when you get to talk to some of these hospitals, they claim that they don't get their reimbursements on time. And that is basically what the government has been investing the most, giving women maternal care. Next. So we have seen that governments are still bears the greatest responsibility to ensure that all those issues are worked out properly. And so we have been engaging governments if we find that their ownership is important, especially for sustainability of our projects. Although there are very many challenges when engaging governments, one of our strategies that we have employed is that we've left government to lead the process of implementation. And so we make them aware that it is their role to make sure that these services get to reach the community and women and get to reach them in good quality. And so when we have projects, we then ensure that we let them lead that entire process of implementation and that our interventions are backed up with data. I might not go into all those because of time. So we'll go to the next slide. The next pillar that we've also noted is a coalition building is a great addition to our work as civil society organization. And so most of our work, as much as we engage government, we also are very keen to build on the alliances that we already have to ensure that we get to our voice amplified even at that level, so that the government will then listen to some of the issues that we are raising. Our experience, particularly as taught us as CSOs, civil society organizations, must work in alliances to guarantee optimum results. We have implemented in alliances for purposes of sharing information that is very crucial in influencing policy and budgets. We have jointly amplified the community voices, because at the end of the day, if the communities are not the beneficiaries of what we do, then what we do is in vain. So we've made sure that we bring the community voices to the table, and that the policy makers get to listen to what the community is saying, and go ahead in monitoring progress and ensuring accountability. And accountability, for example, is more effective when done as a group as opposed to done as an individual, because in certain cases you will be victimized as one civil society organization going head on with government, as opposed to us coming in as a team, so that there will be no one really to be at the line of attack. In most cases, the work that we do at times is very is viewed by government as not very good to them, and so there is always lines of attack. You're invalidated, your records are looked into, your tax returns and all that. And so we found that when you work within those spaces as CSOs jointly, then it is more effective for us going forward. So last slide, kindly. I'll go briefly on the COVID impact. I would not want to dwell much on it, as most of it has been said previously, and we have seen some of them in the news. But to note, in Kenya, we have slashed our universal health coverage budget, because we were in the process of rolling out the country's UHC, and that budget has been slashed off to then now cover our response for COVID. We have seen health workers threaten to go on strike, because some are being given allowances, some are not being given allowances. For even in that, there is a little bit of inequalities going on there. But as my parting shot, I would like to bring us to the attention that COVID-19 is here to remind us that the health sector is more important than the economy, because it can bring it can bring an entire economy down. And that is what we have been trying to engage with governments to no avail. But I hope that this then sounds an alarm that if we don't take care of our health sector, the economy that we sweat so much to take care of can go down in a minute. And lastly, sexual reproductive health rights must go beyond maternal health. That is what we have seen being given more attention, to include contraceptive prevention and treatment of cervical cancer and sexually transmitted infections, prevention and response to gender-based violence, and safe abortion services where legal. There is a tendency to assume that maternal health programs are an adequate response to addressing differences in health between sexes. The road to UHC, however, must include women as key partners and decision makers. We know that much of the progress in health has been attributed to the tireless work that women and girls organizations have put in, but their voices right now more than ever must be heard in creating policies and legislation for health and in monitoring progress. We must remember that even in the middle of a pandemic like the one we are experiencing right now, their sexual and reproductive health rights cannot wait, because even in times of crisis, sexual activity will continue, personal autonomy and choice will be compromised, and pregnant women will deliver, and complications will arise. So we need to make sure that we factor in, even as we go on into the COVID-19 debate, that SRHR is not left behind. Thank you very much.
Thank you so much, Patricia, and for raising some very critical issues and reminding us about the importance of health in terms of how, you said it so succinctly, that how we can bring an entire economy down, and all those critical issues that you raised on SRHR. We look forward to having more discussions on that. Patricia was our last speaker on this webinar, and so we will now enter the Q&A. We have already received some questions in the Q&A box, and we will try and I will try and specifically flag these to specific speakers for whom they've been addressed. But to begin with, I would like to invite Dr. Nono to talk briefly about the key messages. I think Dr. Nono, I had to cut you short because we were running out of time. But if you could just flag those very important key messages that you were not able to present at that time. Over to you, Dr. Nono.
Thank you. Thank you very much, Deepa, for this opportunity. I think, the most important message or messages that I would like to share, which have also been amplified by other speakers, is first of all, solidarity. Solidarity not only at the global level, not only for global health institutions, but for ourselves. We as a community must remain committed and together in doing the things that we need to do, holding governments to account, you holding us as WHO to account for the things that we are meant to do that we are not doing well. The second thing that we need to really be focusing on is ensuring that we use the experiences and lessons learned from this pandemic to strengthen the provision of comprehensive services for women. I know that we all feel strongly about the issue of access to SRHR services, especially in the face of so much pushback. We have to amplify this. I think we were very saddened by the fact that we had to postpone Beijing Plus 25, but I think we go to Beijing Plus 25 now with solid evidence of why countries and governments must invest in primary healthcare services that are equitable, that are community-centered, that are orientated to the needs of people. So women don't have to fit themselves into a rigid system, but the system is pliable and agile to respond to the needs of women. The third important thing is that we have reinforced multilateralism at the top, but that does not mean that the role of other critical players, which is communities, civil society, women, the faith-based sector, and everybody across the continuum, across all sectors, must be part of this. Multi-sectoral action is the most important ingredient for taking the work that we are doing in the health sector forward. We've got to focus on those things. And I think as members of this coalition, we individually have access to power, we've got access to opportunities, and we need to use those to ensure that we bring everybody on board and we continue to amplify our work. We will be coming out very soon with new estimates on gender-based violence as WHO, continuing to provide this evidence that the world needs to see the impact of violence on women and girls, and to continue to fight these restrictive laws that prevent women from getting access to care. So for us, quality health services, integrated, responsive, across the life course, that are women-centered, people-centered, equitable, and high quality as part of primary health care, but most importantly, without creating financial catastrophe for women. What I've just heard happening around Kenya is something that we really need to take forward and see how we can resolve this limitation. It's not just Kenya alone, many countries that don't provide comprehensive packages of care for women. Then the second and last thing that I really want to emphasize is the importance of ensuring that we maintain adequate, appropriate, high quality and correct information for communities and for people who are responsible for the services that women receive. More information, I think, is available on the slide. I hope that any questions that come through to WHO will be able to take, and if not, we will send more information to the colleagues that are participating in this webinar. Thank you very much.
Thank you, Dr. Nonu, for flagging these very important issues. I would like to flag the next questions to Rosario. The questions that have been raised was about the fact that you mentioned low neonatal and maternal death rate, as well as low adolescent pregnancy, but also that Chile lacks sexual education and abortion laws. So the question is, how have those things been achieved and what interventions have been successful? Rosario, over to you. And if you could keep your responses brief so that we can cover more questions, that'd be great. Thank you.
Yeah, of course. Well, I think that the main facts that are helping us in our rates, beyond that we don't have sexual education, is two main things, two main actions. One is that in Chile, every woman upon 16 years can ask for a midwife's consult in the primary health care, where we provide different kind of anticonceptive methods, and they are provide them for free. So there we have, but like just like a little short education, and more than education, we just like give medical prescription of it and give it to the patient. And also the other factor that has helped us a lot, especially in adolescent rates, pregnancy rates, is that we achieved a few years ago to start the emergency anticonceptive pill in pharmacies with no medical prescriptions. And our patients are really using it, so that has helped us a lot. So the thing is that in Chile, what I realize is that women and like couples, especially young couples, are taking care of not getting pregnant, but they are not realizing, because they don't have sexual education, that the act of sex is not only leading them to pregnancy, also to diseases. That's why our HIV rates are in outbreaks. I don't know if I make it more or less clear.
Further questions or clarifications on that, we could come back to you.
Okay.
Yeah, thank you. There are a couple of questions to Dr. Tadesse, but I think she has already left, so she won't be able to respond to those. Arush, there is a couple of questions for you, which I'll flag here. So one of the questions was about the UHC status. If you think that a country's UHC status has influenced their ability to manage, the various issues that were raised in the presentations today, do you have any kind of reflections on that? And the second one, I mean, there were actually 3 questions, but I'll just flag 2 for now, and to see if we have any other questions. The second was if you could elaborate on the vertically sliced funding streams point. Over to you, Arush.
Sure, thanks so much. I think that question on how UHC status has influenced countries is a really, really poignant one, because we're seeing how countries that have strong history of UHC and the type of culture that comes out of that process has actually really improved their ability to manage COVID-19 and other outbreaks in the past. Just for an example, Kerala, it's a state in India, has a very strong history of UHC. They have a very strong commitment to health workforce. They are, I think by no coincidence, led by a state minister that's a woman. And they have a strong commitment to education as well. And these factors we've seen has made Kerala's response really stand out in a positive way out of the rest of India's states. They've had the most effective response. They've been very cautious. They've been proactive. And they've also done what I think is important is they've addressed the social determinants of health as well. They've provided housing for migrant workers. They provided cooked meals. They've done advanced pay on pensions. These kinds of things that are often inherent in stronger UHC systems are really good in helping mitigate crises like COVID-19 as well. And we're also seeing this similar thing play out. And I think US is a very standout example that a country that does not have strong UHC, has very big fragmentation, and does not have a history of trust in health systems and health services, is one of the largest, has one of the largest caseloads. And so I think that definitely has a big role to play. In terms of the vertically siloed funding streams I was mentioning, priorities in governance have a huge impact on public health and are often not included when you look at assessments on preparedness and readiness or UHC. But the way we fund UHC systems has a huge impact, because during crises as well, it can offer an opportunity to really, have a target on certain sources. So when you're funding HIV specifically, or sexual reproductive health services specifically, or TB, and these are not integrated in a UHC kind of continuum, they become easy targets during a crisis, because you say, well, we need to focus on emergency response. We don't have time to focus on these routine health services. And very quickly you see rising rates of inaccess to medicines, lower rates of, reported heart attacks and breast cancer screenings, these things, which are going to have larger impacts primarily for women and vulnerable populations down the line. So I think vertically siloed systems are a huge inhibitor to stronger, comprehensive UHC that's equitable in the long run. Thank you.
Thank you so much, Arush. I might come back to you later with a question if you have some time. The next question, Patricia, if I may direct the next question to you. This is a question by Marissa from research. And the question is, as we are witnessing increased emergency powers, criminalization, punitive and mandatory measures related to COVID crisis globally, how do we ensure that these measures are not impacting women's health and SRHR more broadly, especially for already stigmatized and marginalized communities, including learning from the dangerous histories and current situations of criminalization of HIV transmission and exposure, for example? Over to you, Patricia.
Thank you, Deepa. I think that is a very good question. And one of the things I've said repeatedly since COVID started is that human rights cannot be suspended just because we have to deal with COVID-19. And that is what we have seen in Kenya and in other countries, that human rights have been suspended. In Kenya, for example, we are currently facing floods as well. People have been displaced. Sexual violence is on the rise, and we have curfew that has been imposed. So between 6 to 5 a.m., 7 to 5 a.m., you cannot be seen outside. And so we have found police beating up people. We have found quarantine facilities. People do not have masks in quarantine facilities. People do not have sanitizers. They are bundled up in a room. If you're arrested during curfew hours, you are taken in for quarantine by force. Initially, we were being subjected to paying for quarantine. And what we did was to come up together as civil society organizations and to say that we will not pay for lawful detention, because that is illegal. But people paid for close to 3 weeks before it was scrapped off. So I would say that we need to be vigilant as civil society organizations. We cannot suspend human rights to deal with a pandemic, and we must make sure that we let the government know that as much as you're dealing with acceptable, you cannot kill people just because they have been found outside during curfew hours. You cannot bundle people into rooms as if they are not human beings, just because that is what you can offer as a quarantine facility. So there is need for us to regroup. And there is need for us to be extremely vigilant as civil society organizations, so that we do not let any injustice pass without us saying something. Because it's that little voice that we can come up with jointly to make sure that action is taken up. And for us as a country, we have seen that every time we've come up together, to rally behind people that are suffering, people that are victims and survivors of this pandemic, then we are stronger together and we can ensure that government listens. And so I think that would be my input on that. Human rights cannot be suspended because of a pandemic.
Thank you so much, Patricia, for your answers and for also providing us some illustrative examples from Kenya to what's happening there in terms of punishment and punitive measures and criminalization. Thank you so much. I think we have time for maybe a couple of questions. So Rosario, if I may direct this question to you. The question is, how do we ensure care and support and empower frontline workers, especially frontline women workers? Over to you, Rosario.
Sorry, can you repeat the question?
How do we ensure care and support and empower frontline workers, especially women frontline workers?
Yeah, well, I think that for ensure the APPs that we are needing as, for example, midwives, I think we must work like in teams. For example, here in Chile, since we had felt invisibilized as midwives, we organized like all Chilean midwives and ask and speak to the ICM, the International Confederation of Midwives, to inform them how is our situation and ask for support so they can help us to be visualized like by the health of minister here in Chile. Of course, social medias always help, but I think that the most important thing is to work as a team. We need to see a team of women, of midwives that are exposing their needs. And in the empowerment of women, I think that's like really different in the case of every country, of course.
Thank you, Rosario. Dr. Nono, can I direct a question to you? This question is about whether countries are collecting and analyzing data with regard to, I think this is with regard to COVID-19 and maybe SRHR. And also, if you could specifically, I mean, kind of really elaborate about the Solidarity Fund.
Deepa, this is Courtney from Women Delivered. Dr. Nono had to jump off the call, so perhaps this is something we can direct as a follow-up question and share answers in writing.
Yeah, and I was wondering if Arush, you wanted to take that question on data?
Sure. Could you, sorry, I had a little trouble hearing. Could you just...
Yeah, sure, I can just, so the question was whether countries are collecting and analyzing data. And I think this is probably on gender disaggregated data and on multiple vulnerabilities that women are facing. And I mean, this is important. I think you raised it in your presentation too, on the intersectional data, disaggregated data.
Yeah,
so
no,
give us some, yeah.
Sure. Yeah, I think I'd mentioned, yeah, I mean, for COVID-19, at least in particular, we've seen only about 40 countries are tracking sex disaggregated data. And even fewer of them have disaggregated data by the social determinants that I think you're mentioning, like different types of structural inequities. Makes it a huge issue. And it's also kind of perplexing to see this because, you know, we've seen largely initial data show that significantly higher mortality for COVID-19 among men, almost around twice the rate in some countries as women. But you know, Qatar has almost 91% of men that seem to have COVID-19, and yet other countries do not. Finland actually seems to have more cases in women. And what does this mean? We don't know, because we are largely looking at this blind. There's not a lot of comprehensive data, and especially transparent data sharing is an equally large issue, because a lot of these things are not shared publicly. So I don't know whether that answers the question, but I think the root of that issue is we do need more data, and there just has not been as much as there should be.
Dr. Nono's not on the call, but in addition to the question was also why the WHO data does not really reflect disaggregated data, especially gender disaggregated data. So we could possibly direct some of these questions to her, and she'd probably be able to respond later. So yeah, those were some of the questions. And do we have some time? I think we should probably wrap it up now, because we don't have much time left. So I just want to say that there were some very critical issues that were raised, and I'll very quickly, and I'm not going to try and summarize, it's impossible for the range of issues and that were raised. But I think that a few things that came up, and what Patricia said in the end really stuck in my head, that human rights cannot be compromised at any cost just because, you know, there's a pandemic that we are dealing with right now. And I think that is something that all of us in our countries need to remember and be accountable to. And the other thing was that there are no shortcuts when we talk about UHC and gender equality and sexual and reproductive health and rights. And this was very evident in the experience of Ethiopia. And as all our collective experiences on COVID show, UHC and gender responsive systems are imperative in both non-pandemic as well as in pandemic situations. So this just cannot happen overnight, but it needs to be worked and sustained. And strong health systems and primary health care, as experience indicates, is a key strategy for defense against outbreaks, a lesson for UHC from COVID-19. It is imperative for all of us to acknowledge and implement, acknowledge that SRHR policy and implementation of services are essential, and that these are rights, these are human rights, and those who seek them in the context of the pandemic and other situations of conflict or disasters, but also in non-crisis situations, must be addressed. And the importance of healthcare workers, especially frontline healthcare workers, and a majority of whom are women, was reiterated throughout this webinar. And I think it's a very critical issue, and we really need to see how this can be, you know, addressed, and the way that healthcare workers have been treated historically, but also during the pandemic, which is a reflection of that historical kind of, you know, fault lines, can be really addressed and challenged. I think Dr. Nono probably said that health is a pathway to development, prosperity, and security, and was reflected by other speakers. And that global political leadership must acknowledge and build back better, and it cannot be business as usual. And unfortunately, however, like the country that I come from, which is India, we just had an announcement of a budget for health, and it's abysmal. It's really paltry, and we see what's coming or not coming in the next years. So that's really sad. Multilateralism and global solidarity to combat structural global inequities is critical, and this is something that also was flagged during the webinar. Political commitment was another very important issue, along with the availability of disaggregated intersectional data. And when we talk about data, I think there are also huge concerns about surveillance and privacy. So we didn't have much time to talk about that, which is very, very relevant to sexual and reproductive health and rights. So in this context, the fight against indifference, I think, is what Rosario had flagged, is so relevant. And the experience of COVID and the response to it has reflected political and social indifference in many of our parts, and apathy in many parts of the world. And this situation really needs to be transformed. And we need to move beyond today's context, which is unlikely to happen automatically and requires sustained momentum. So on this note, let me remind interested participants wanting to join the Alliance for Gender Equality and UHC that the link was shared in the chat box, and it will be shared by email after the webinar. So please do join the Alliance in the struggle for gender equality and UHC. To all the speakers, participants for making time to be part of this webinar, and to the many Alliance colleagues who have been working tirelessly to make this webinar happen, a very big thank you. Stay safe and take care. Thank you all for taking time out to be part of this webinar. And I would like to say goodbye and warm wishes on behalf of the Alliance to all of you.